Good afternoon to all. So we proceed without deliberations, strictly observing the agenda, and we have to congratulate all the previous speakers and moderators for keeping that agenda. But since we speak of innovation, let us innovate and observe the agenda for a change. I have the joy to moderate a panel which is extremely demanding, and you can see it by the title, that is Sustainable Funding for Sustainable Healthcare Transformation. You realize that if we win this wedge, there's no reason for other conferences. Everything will be solved. The truth is that the major wedge is precisely this, sustainable funding, but also combined with sustainable operation and the best possible results. I had the joy to have with me this panel, excellent scientists and high-ranking executives in the system, and therefore they can really frame the subject from different viewpoints. We have Madam Karpodini, Daphne Kaitelidou, Elena Chouliara, and Mr. Gkikas, who will give their own viewpoint in this subject. So let us start with a basic representative of the state, the main payer that we have in the system, with a brief introduction, asking her to comment the new environment shaped and what is to come from the EU and other organizations, claiming that you must invest in research, in new drugs, in the seamless supply of the market, and of course all that demands sustainable funding. And you realize there that the role of EOPYY is critical. So how do you view things? First of all, let me thank for the invitation, the Hellenic American Chamber of Commerce, and you personally, Mr. Souliotis. Indeed, this era is one of the most important challenges for the healthcare systems. You have identified that on multiple occasions, both the academia and other institutes. As you mentioned, according to the recent Draghi report published a year ago, the main pillars through which all European states must get in tune is enhancing R&D, securing supply with medicines, and the boosting of digital transformation, because without reliable data in health, we cannot be effective. I believe that our country can claim a sort of innovation in the field of enhancing R&D and innovation, because, you know, for more than 5 years, we have been implementing the investment clawback, which is an incentive both for Greek and foreign companies to invest in innovation and research. At the same time, we have asked for technical assistance already received in order to boost the health technology assessment. And we should not ignore the recent statement of the Prime Minister in Thessaloniki for the establishment of the Innovation Fund, which sets the priority to covering uncovered medical needs and innovative treatments. At national level, we also participate in the European, through the European Commission, with an effort launched in order to secure access of European citizens to critical medicines, and we also invest there for the strategic autonomy of Europe. Let me point out that Greek companies have great participation, great contribution in that, and our country feels confident and strong because we have a very robust pharma industry, and we believe that a lot of critical medicines, once we create a more friendly and flexible framework, will be an advantage. Thank you. Madam Kaitelidou, for many years, we used to consider that setting the priorities in decision-making process, that quality lags behind, or one might sustain that was even a luxury. The important would be to meet the needs, to secure a minimum, a specific framework of health services, and let no one behind. International literature, however, claims differently. What do you believe? Representing, of course, the Organization on Quality, securing quality. Thank you for the invitation. Let me say that indeed, for many years, quality was merely a theoretical notion and a very popular subject in conferences. That is, we would all discuss about it. But actually, the interlinkage of quality with resilience of health systems was left vague. Seeing international literature, and we can see it from that, recently an OECD study mentioned that some 20% of health expenditure is actually wasted in low-quality services or totally redundant. So just think of it. That entails more than 2 billion euros. WHO also recently assessed this damage at the damage is caused by the health system per se at 10% of interventions. That is, 1 of 10 patients will be damaged because of a system that does not have a quality assurance framework. And hospitals that Madam Karpodini has to pay earmark more than 10% of their budget in order to correct those damages. So indicatively, to say on an issue that concerns our country, which is infections, which is number one risk in patient safety. Since we are in the AmCham, Americans have calculated the cost caused by inflammation more than 1 billion euros in the USA. With well-targeted interventions, they managed to save most of that sum. That is, they estimate they save 25 billion per year due to infections. We actually have double the rate in infections by EU and almost double from CDC, the American standard. And there are so many, numerous examples. The post-operative sepsis, for instance, costs more than 55,000 euros in order to deal with it, if we may deal with it. I don't speak of lost lives, total and permanent impairment, and so forth, or a mere necessity condition of a patient bedridden due to an operation. So actually, quality is not something theoretical, neither is it a luxury. Nevertheless, in the healthcare system, not only in Greece, but elsewhere as well, we consider it an addendum, if you like, in the discussion. We must realize that it must come to the nucleus, to the heart of the discussion. It is interlinked with the efficiency and effectiveness of the health system. The deaths caused due to lack of health system quality are more than the ones caused due to the impediment in the access. So access is very important, but more importantly, the point is not to cause damage to the patient because of the current status of the health system. And no state has managed to face that. And our country, to play our own drum, if you like, made a step, established this organization, ODIPY, which had not existed. There was no scientific work in situ on the matter, so that was an important step. ODIPY, which is the Organization for Securing Quality in Health. But because now we know that quality does not only save lives, but also secures sustainability, that it saves a lot of money. Why don't we invest in quality? What do we do? Well, I could actually tell you that there is a counter-incentive, triple counter-incentive. And I elaborate, in order for a hospital to offer quality services, must invest in training the personnel, must invest in introducing procedures so as to limit the imbalances and the lack of single system, to introduce processes for redundant tests, lab tests, for instance, must also invest so as to deal with the errors of the medical treatment. These resources have to be found by the provider. Furthermore, what is reimbursed is poor quality. That is, a health service provider will be reimbursed for the additional hospitalization days, which may be many, more than 11 in the case of sepsis, will be reimbursed for the hospitalization days for the damage they have caused. Actually, therefore, there is no incentive for introducing quality in the health system. And I conclude by saying that it is very important for the country quality to come to the heart of the strategy of the Ministry of health providers. It is important to start calculating it, measuring it in continuum. That is, quality metrics. It is now that we start introducing that. And this is the way to boost the improvement and maintenance of that improvement. That is, feedback is most important. And finally, the value for care, as we say, that is, funding must be connected with health services that are of real value. I believe this is the way forward. Fine. I think quality is like prevention. We know it will pay back, but we mean front-loading. And that's why we have to earmark and have funds now that will pay a yield later. But of course, now we see it. It's like EOPYY. It doesn't have open and limitless funding. It assesses and will also undertake more responsibilities. So we're moving to the right direction. So that was, you passed the torch in an excellent way. So I come now to Mr. Gkikas. As far as reimbursement of the services, there is an interlinkage with quality, or to be more precise, with the level of equipment. How do you view those steps? Well, first of all, let me say that it is a privilege to be in this discussion, and even more so because I speak after the first two presentations. Because indeed, by representing our committee in the chamber, the members are the biggest multinationals in the field. When they start introducing innovation, after having identified the clinical need, the first priority they set is how they will attain and meet this need with quality. It's the first prerequisite. This is precisely what we describe when we come to submit our file in front of the prospect investors. So this is the first thing. And the second is what we are to produce, how it will be sustainable. This is how innovation is built, which can eventually reach the field. The problems start when they reach the field, because the providers, that is, the health services buyers, have to focus on the subject of sustainability, while the receivers, the receptors, who are the citizens, need mostly and focus on the side of quality. And medical technology, who is a leverage actually, we have to strike a balance between these two. What happens in Greece? We try, while trying to attain the sustainable part when buying health services, we mainly view the constituents having to do technology as characteristics. And this is where we miss the broader picture on how these characteristics and attributes offer quality to the end users. And this is there that we've got huge improvement margin when we focus on the patient, on how the patient will not only improve but also feel better once the services are offered. Thank you. Madam Filiara, to come back to the main subject, sustainable funding. You represent an innovative pharma industry, Zeneca. Quite often, we hear you referring to the funding of medicines, saying that it doesn't suffice. Would you like to elaborate on that? There are many views on the subject, and I would like yours. Good afternoon. Thank you for the invitation, being in this interesting panel, which tackles a very important issue in the field of health. So I will have to reiterate that unfortunately public funding doesn't suffice, not only today, but according to all prospects, the situation in the near future will not improve. Quite the contrary. I say that because it is not by chance that currently Greece is by far paying the biggest clawbacks from pharma industry to the state, especially when we've got an original price, which is de facto by amongst the lowest in Europe. Watching statistics with regard to the overall public funding of medicines, we see that Greece lags behind vis-à-vis the other EU states. On some calculations, because we wanted to calculate what should be public funding in Greece in relation to the other countries that we are compared with similar conditions, we've seen that currently what we lack from the system are more than 1 billion euros per year with regard to this public pharma funding. Efforts have been made for improvement of the situation. It is true that after more than 10 years of stagnation, we witnessed some increases of the state funding. However, those increases do not suffice. In the last 3 years, 22 to 24, the public pharma funding remains stable as a ratio to the GDP. Why did I say that things will turn worse in the future? Because focus 2023 to 2028, the pharma expenditure in Greece expected to rise by 5.5% per year. This is not exaggerated or too high. It's amongst the normal, below the 6.3%, which is the EU average. At the same time, public pharma expenditure, according to the statements, even taking into consideration the 50 billion, will increase by 5.2%. So when the overall expenditure rises by 5.5 and the public funding rises by 5.2, we see, pure mathematics, that this gap of 1 billion will not close, quite the contrary. And this multi-annual underfunding in the pharma field has shown its impact. The best measurement for innovative pharma industries, the right measure, is the access of Greek patients to innovative medicines as registered by the EOPYY weight study, where we see a continuous exacerbation as a rate of the innovative drugs in the latest weighting. And now we've reached a 55% of non-availability, when 2 years ago it was 50%. So we see an ever worsening course. What should we do? We definitely sit around the table, the state, academia, patients, and the industry, to find solutions that will boost the funding of the system, of the medicine system, so as for both our patients to have seamless access to the needed medicines, but also to have an environment that will be sustainable for all the stakeholders and involved parties. Thank you. Thank you. I will continue with you so as to conclude with Madam Karpodini. And on the basis of the debate, it's easier now to turn a second question to you. Having said that, let us be realists. Find all of a sudden 1 billion to be channels in the market. We know that it is highly improbable. Furthermore, if we want to meet somewhere, both sides must find a way to increase funding, and the other should find ways to support other measures that will rationalize the expenditure, so as to meet somewhere in the middle. That will be a more realistic scenario. There are also other structural measures that have been announced and are currently being implemented. Do you think that they can help towards the direction we're asking, that has a sustainable, resilient funding system?
First of all, I would like to say that I agree with what you said. We cannot talk exclusively about increasing the funding. It is even more important to ensure the efficient use of resources. And since the initiatives that have been taken lately and the progress that has been made, like, for example, the establishment of different boards or even the announcement of the plan for transitional reimbursement, all these different initiatives are in the right direction because they ensure a more effective use of the available resources. I believe that all the different stakeholders need to sit around the same table. That is, the industry, the state, the patient associations need to come together and take initiatives, plan actions that will be part of a wider framework of a medium and long-term strategic planning. But of course, there are some risks involved in that and in the initiatives that have been announced or are currently being implemented. The risk is that these may be fragmentary and will not lead to the establishment of an integrated system. If I had to choose some areas where we should promote reforms, areas that need to be given priority, the first would be digitization of health data. This was mentioned previously by Ms. Karpodini. We have a wealth of data that we can leverage. And if we manage to collect and use this data in an effective way, then we will be able to use them as a basis for informed decision in the health policy sector. Another area is the area of prevention programs. We need to invest further in these. What has happened in Greece is actually quite impressive. We need to find more national resources so that we can continue with these programs that first started with the RRF, and we then need to expand them. Recently, we heard the program for obesity and renal disease, but of course, we need to identify more areas we can have bigger impact. And if I need to focus on medicines, and on the reforms that need to be taken priority and be accelerated, the one has to do with the HTA organization. It is important to have an organization with permanent and specialized personnel. Otherwise, we won't be able to deal with the challenges related to HTA. And another thing that can play a very important role in reforms is the plan for transitional reimbursement, or the so-called innovation fund that has already been announced. And of course, that needs to be further clarified. And that is why we have arranged meetings with the ministry and with the other stakeholders in order to get these clarifications. But of course, everything comes down to funding. The 50 millions that have been announced do not suffice. In conclusion, because I can see you looking at your watch, Mr. Souliotis, I would like to say that it is important to ensure that any initiatives taken are taken in the wider context of strategic planning that is based on two pillars. The first pillar is the pillar of funding, and the second one, the pillar of reforms that are absolutely necessary for ensuring a better use of the available resources. Of course, I agree. We need documentation, we need data, we need continuity and not fragmented interventions, and we don't want any surprises. The state should not surprise the market. On the other hand, you will allow me to say that these measures that have been announced, the HTA, the Innovation Fund, that is, they need to start operating. And then we will see if there are any areas that need to be improved. We need to start. We have the organization, Ms. Karpodini will take the floor in the end and talk about all these different programs and how they will be funded, because we know that funding is the decisive factor for a sustainable health system. Mr. Gkikas, your market is not that regulated as the pharma market is. The pharma market is over-regulated. So many different interventions often cause confusion. How do you see the reforms promoted by the central administration? I would like to say that the effort made by the medical industry is to bring innovation closer to the citizen. A few years ago, a reform was made by EOPYY in the direction of ensuring new generation medical equipment in the country. This was a very positive step. Of course, more state-of-the-art equipment doesn't necessarily mean that it is an effective equipment, given that technology advances at a rapid pace. What we need to look at is the sustainability that can be ensured by making specific interventions, which do not require heavy investments. The only thing they require is for us to identify what can bring value in the provision of care. For example, when a patient feels more comfortable in an MRI, or when a woman feels more comfortable during a mammography, or when a test can be performed in half an hour instead of 1 hour, this actually ensures effectiveness but also comfort for the patient. And it encourages them to come back and take the test again. And this is what creates value and productivity. So now what we need to do is to make the next step, move forward and see which are those elements that constitute innovation and how we can reimburse them, so as to provide incentive to those who are providers of care to invest in this. Otherwise, as it was said previously, they will just provide a device which will not be the best. It will just be sufficient in order to justify the reimbursement. This is not what we are after. Yes, of course. We should be careful of not turning all these provisional services into mass services, because this may be to the detriment of quality. If you take a look at the description of a scanner, for example, or of another device, you will see that they are 4 or 5 pages long instead of a half page long. So we need to be careful, but at the same time effective. Mr. Souliotis, dear colleague, the truth is that up until recently, ODIPY was absent. Once it was established, many needs emerged at the same time. So the first thing I would like to say about ODIPY is that it needs support and strengthening. It needs staff that is scientifically trained so as to cope with the demand that is very high. And this is a good thing. The fact that the demand is high means that the providers need the assistance of ODIPY. They want to be measured. And this is something very important. So one of the things that ODIPY has done to date and will continue to do in the future, since the way is long, is to assess the current state of affairs by using indicators. It is the first time that the country uses hospital indicators. This is exactly how the organization started, making this very important step and using indicators. And then, of course, inspections and evaluations conducted by the teams on the field. This is something that will help EOPYY a lot. EOPYY will have documented information, quantified, because we do have a clear idea of what we mean by quality. Quality is something that can be measured through the use of indicators, tools that are calibrated, documented. We do have a picture that is a very good one and will help us continue in the right direction. Now, in the hospitals, the work that has been done has set some very good foundations. Where we are lagging behind, actually, and I believe our organization can change this delay, is primary healthcare. We need to support and enhance primary healthcare. The steps taken in the direction of screening and other tests were very important, but at the same time, there has to be coordination and continuity. Right now, we have a program that is running massively. It is a very important one. This program needs to be well coordinated, and we need to ensure its continuity. Otherwise, it will be a one-off program without good results. So EOPYY needs to collaborate with all stakeholders of the primary healthcare sector so as to set some qualitative criteria, coordinate the work of personal doctors. It is very important for them to know what we expect of them. They have contracts, okay, but we need to determine precisely what is expected of the personal doctor. This will be valuable assistance for EOPYY, who is the basic payer, and who needs a clear picture of the providers. In conclusion, I would like to say that it is very important for this evaluation, and by the way, there is this evaluation being done in the public sector, to continue. EOPYY has evaluated over 50 hospitals. We have a clear picture of what's going on, and we have identified some common weaknesses that are being repeated. This is very important because it allows us to develop some targeted strategies in order to deal with them. This, however, should be expanded to the private sector. This is a deep belief of mine. When it comes to patient safety, private sector needs to be evaluated with the use of the same tools, same indicators, so that EOPYY can have a clear picture of who are the contracting parties, what they need. And EOPYY has actually set up some criteria for the very first time. And now what needs to follow is synergy with the contracting parties. Moreover, for us, the workforce, the human capital, not only in terms of numbers. Okay, you need to have the right amount of people working in the system, but equally important is for them to have the right skills and the right expertise. If we manage to ensure that, then our people will be able to keep up with the developments in the medical sector, in the management sector. And of course, this can only be done, and I'm glad to see Mr. Boubas in the audience, through continuous training. It is a very basic pillar, and I believe that there is room for improvement, for cooperation in the future. Thank you. The truth is that for many years, the organizations of the healthcare sector were operating on an autonomous and independent base. KEFI was doing what it was doing. The payers were operating differently with different packages of payments. We didn't have any quality assurance organization. Now, the truth is that there is the necessary framework for an integrated intervention in the healthcare sector with the use of indicators, which, in my view, should be used both in the public and in the private sector. Since we have a payer, we have a system with freedom of choice. Other countries don't have the same freedom. And the catalyst for this freedom is EOPYY, that is contracting with public and private organizations and provides more choices to the insured. This is the tool that we have in our arsenal that actually met fierce resistance when it was first introduced. And all these studies pertaining to the health of the population with epidemiological data or the health needs, the services rendered, the quality of services rendered. We want to see all these things presented in regular reports. Okay, ODIPY will have a report, will negotiate the amount of reimbursement, but we want all these reports and information to be accessible. This will be highly beneficial for all because it will allow us to set priorities, see where we need to invest. And one last thing, since you referred to the personal doctor, approximately 75% of the population has access to personal doctor. 90% states that it has its personal pharmacist. 90% of the population say that, yes, I go to the pharmacist that I trust, that I know, that knows my problems, and with whom I have a very close relation. And I would like to ask dear Ms. Karpodini, whom I would like to thank for coming, despite the fact that she is slightly sick. So I have two questions for you. First of all, home delivery of drugs. This was a promise made many years ago, and now it is a reality. I would like you to comment on it. Associated with that is the issue of FIC in the pharmacies, which, in my view, will increase the access of patients to drugs. Could you comment on this too?
For the question. Indeed, the high-cost medicines delivery is a reality. Starting from June 16 until today, 3 months have gone by. We have 100,000 deliveries through this program. 15,000 were home deliveries or office delivery, whatever the patient opts for, and the remaining are specific distribution hubs all over the country, especially in the countryside, where we do not have specifically designated EOPYY drugstores. Our patients, chronic patients that take their drugs from the EOPYY drugstores have embraced this initiative. We have exceeded 2,000 deliveries per week from the third week of operation of this program, and we see every day that this action is highly trusted and further embraced. Now, to view what you said about private drugstores, and I will be crystal clear. Let us see where we agree and where we disagree. Recently, the Minister of Health has established the scientific fees of the private drugstores so as to be able to offer the high-cost drugs. This fee is specific, quite higher, triple than what home delivery costs us. So by default, on the basis of the fiscal criteria that you in the academia very well know, limits this possibility up to a budget, up to a fund that public budget can afford. What is pending in order to introduce that is to have the issuance of the ministerial decision, which EOPYY approved in its board of directors before September, on the basis of the mandate given by the law, so as to designate the procedure on the basis of which specific active substances and drugs will be delivered through the private chain. Nevertheless, this ministerial decision is not issued yet because some limitations and conditions are set by the Pan-Hellenic Pharmacists Association that goes against to our will to have as many new channels closer to the patient as possible. For instance, we cannot limit that each drugstore will have 5 prescriptions only, and instead of having the patient going at 10 or 20 meters, will have to cover 500 meters. This must be understood. We cannot satisfy trade unionists' claims. We do not operate this way. Recently, furthermore, you must have read in various in the mass media that the Pan-Hellenic Pharmacists Association has submitted a claim of cancellation of the home delivery. So we're against. We are for the patient, not for the trade union of pharmacists. We must handle and manage our budget in the most effective and efficient way and reach the patient as close as possible. So in the effort to abolish such an important channel covering patients who have either mobility problems or have no access to any distribution channel, we are definitely against these trade unionists, and we do not agree in any way. Therefore, in order to be crystal clear, no matter what is to the benefit of the patients, whatever is for the benefit of the management, the reliable management of public funds, yes, we are for it. Whatever tries to limit this access and weaken important services offered to the patients will find us against. Well, I'm not familiar with the details of the overall discussion, but allow me to voice my thoughts. If I understood, there is a claim to limit the number of the drugs which each drugstore may offer. That will, of course, hinder the relation of the patient with the pharmacist. I cannot understand whether I have my own pharmacist and I cannot be served by my pharmacist. That would cause huge hurdles, and I cannot understand benefit. I realized that there must be a claim to have an equitable distribution, but we can't do that. We can't set a ceiling of prescriptions. This intervenes and goes against the freedom of circulation of trade. Yes, well, you did it very well. We cannot, instead of facilitating the patient, to set hurdles, and we cannot allow anyone to take away from the patient any distribution channel. I cannot take away from a patient who is in remote areas, no matter how many they are, where we do not even have private drugstores, that we will not make any effort to deliver this drug. The EOPYY used to do that in the past, and there was huge problems for the patients because the overspilling. EOPYY felt that all laboratories have to have a job. No, the point, our scope is not to offer work to all providers. Our scope is to have the best management of public funds. This is something easily to do so. An interlocutor with good intentions can understand that. There are areas and people who cannot move, who have mobility problems. So, of course, it cannot be the rule for all medicines. And I believe that you managed to apply it in a difficult times, because during vacation time, there is no steady residence. So if this went well, that's a very good crash test. That's indeed how it was, because we had programmed to launch it in May, but there was a delay from the Court of Auditors and so forth. And thus, we started later, in the middle of summer. Indeed, a lot of our citizens are away in the countryside, on vacation, and so forth. We would even deliver in big complexes of secondary houses, summer houses. There were major problems. We managed, nevertheless, to have a fruitful conclusion, and this was still a pilot project. That was a major risk, but we managed. And what I have to reiterate is what you stressed beforehand, that the limitations that we have, and the other speakers have said so, the limitations we have in the field, in the part of expenditure leads us to make certain decisions. What has EOPYY managed with the Greek government? We have managed to offer access to more than 150,000 citizens on a monthly basis, we offer them access to high-cost medicines, extremely expensive, more than 2,000 euros. So the way we limit the cost in the intermediary links, but also secure access. This hasn't been stressed enough. These drugs concern specific categories. There are limits, there's limitation in their production. They come in limited batches in our country. So imagine, how are we to secure the access if the 100 distribution centers become 12,000, for instance? Where will we have storage? Which channel can secure it? This is what EOPYY can secure. And the second is saving more than 700 million euros, which is channeled back to the patients by offering them access to new innovative treatments. So the EOPYY drugstores will be pursued, will be maintained, and every effective and financially interesting solution that guarantees safety at the same time will be pursued on a constant basis. Thank you. Yes, indeed, when we live in an environment of limitations, such a limitation is also time. I will thank all the speakers for the excellent interventions, and we have to conclude and proceed to the next session. Nobody leaves the room. Thank you.